The presentation I've created today is to go over medications that we give in the cardiac cath lab, including dosages, why we give medications, and contraindications for some of these medications as well. The goals I have for this presentation is that staff will develop a deeper understanding of why medications are given during cardiac catheterization, and then not only will they understand why, but they will be more comfortable speaking to patients about why medications are given during procedures, because a lot of times the nurses or the RCIS techs were giving medications and the physician's working, so the patients are asking us, hey, why am I getting heparin? And then we can be able to tell them why they're getting it and feel more comfortable doing so. And the last goal I have is that staff will understand how to administer different medications via different routes. A few objectives I've written. After participating in this session, staff will be able to verbalize at least 2 medication dosages, including the bolus and drip. They will be able to express how medications given impact patients. Staff will be able to rationalize how comorbidities of patients affect medication dosages and medications received. And after reviewing medications in this presentation, staff will be able to correctly identify routes of medication administration. And for this presentation, I'm just going to mainly focus on medications we give for STEMI patients, including heparin, Angiomax, Cangrelor, nitroglycerin, and Plavix. Heparin is usually given IV before procedure, given IV bolus usually in the emergency department. It will be 60 to 70 units per kg before the procedure, and we give more based off the activated clotting time during the procedure. We do like for it to be greater than 250 if the patient is getting a PCI or a percutaneous intervention, a stent, if you will. If it's less than 250, we notify the provider immediately and we will give more heparin based off of that. Contraindications include known hypersensitivity or allergic reaction, or if they have had in the past heparin-induced thrombocytopenia, and instead of heparin, we could give Angiomax. And not only is heparin really important because it's going to help bring down their or elevate their clotting time, but it's also going to improve their TI-MI flow. And I have a chart on the next slide so we can kind of talk more about what that is. But for heparin, you really just want to make sure that you give the correct dosages. And a lot of times the patients will come in on a heparin drip. We'll turn that off before procedure unless they are going to have further surgery. If we place a stent and they need to go for bypass, or if they need to have a complex procedure done in Atlanta, a lot of times we will go ahead and continue that heparin drip. But most of the time we don't have to, and it's just heparin that we give during the procedure. So just make sure you keep up with your physicians what they prefer with heparin. And this just kind of goes over the TI-MI flow. 0 means complete occlusion, 1 means penetration of obstruction by contrast but no distal perfusion, 2 is perfusion of entire artery but delayed flow, and 3 is full perfusion normal flow. So I read a study that says if you give heparin before, their TI-MI may be 1 versus, and if you didn't give it, it would be 0, and then after it could be 3 instead of 2. So heparin's a really important drug that we give to patients if we can before procedure. So Angiomax is the substitute I was talking about for heparin, also called bilirubin. It is IV anticoagulation giving during placement of PCI. But if the patient has a heparin allergy, we can mix Angiomax with a bag of normal saline, and we can use that as our table flush instead of heparinized saline. For a normal renal function, the bolus stays the same. It's 0.75 mg per kg, but the drip is 1.75 mg per kg. If their creatinine clearance is less than 30, the bolus again stays the same. The drip goes to 1 mg per kg. If the patient is on dialysis, bolus is 0.75 mg per kg, and the drip is 0.25 mg per kg. Contraindications for receiving Angiomax include active major bleeding and allergic reaction to Angiomax if they've had it in the past. Cangrelor is another medication that we give pretty often for STEMIs. It is given IV, comes in a vial. We mix it in a 250 cc bag, and it is used to reduce the risk of stent thrombosis during a STEMI and coronary revascularization. We do use it as what we call a bridge. So we will start on Cangrelor IV during the placement of a PCI, and then after the procedure is over, the Cangrelor will run as long as the physician wants it to. Usually it's 2 hours after the procedure ends, and then the patient will move to PO Plavix. The loading dose for Plavix is usually 600 milligrams, but if they are already on Plavix, it may be 300. And the bolus is 30 mg per kg, and your drip is 4 mg per kg. Nitroglycerin is probably the medication we have with the most different routes. Very often it's given sublingual before procedure to relieve chest pain. It's the 0.4 milligram dissolving tablet. It can be given IV during the procedure to also relieve chest pain or to help bring blood pressure down if the patient is severely hypertensive. Can also be given, we usually give intraarterial at the beginning of the procedure to reduce spasms for obtaining radial access, because a lot of times that radial artery is not very big and introducing something foreign into it will scare it. So you have to give nitro to kind of help relax that vessel right there. And then we can give it IC or intracoronary during procedure to help reduce coronary artery spasms. But the biggest thing with nitroglycerin is you have to watch your patient's blood pressure. A lot of people are very sensitive to a nitroglycerin drip. And also, if it comes in the brown bag from pharmacy, you need to hang it in the brown bag because it will degrade by light. So that's really important to remember, that nitroglycerin will drop your patient's blood pressure. Talked about with Cangrelor, Plavix is its bridge. So we'll do Plavix PO after the procedure, and the loading dose is usually 600 milligrams. Sometimes it's 300 depending on physician preference. It's an antiplatelet used to reduce the risk of instant restenosis, and the patient will be on a dual antiplatelet therapy post-PCI from anywhere from 6 to 12 months. That will include a baby aspirin and a 75 milligram Plavix daily. But what you want to look out for with your patients who take Plavix is bleeding, because it is a blood thinner. Make sure to stress to them this medication is life or death. If they don't take it, their stent could close. And also, if they fall and hit their head, which we need to stress to a lot of our older population, that they do risk a brain bleed, so they need to seek emergency medical care immediately, because that is something that could progress quickly if not taken care of. And these are just some resources I use to create this presentation, along with the nurse educators I have on my unit. But yeah, I hope y'all enjoyed this presentation and that y'all are able to use this. Thank you.